Welcome to another episode of Diabetes Care on Air, a new and different way to bring the research in diabetes care to life. Today, we are featuring the content of the March 2023 issue. My name is Dr. Mike Rickles from the University of Pennsylvania.
And I'm Alice Chang from the University of Toronto.
Before we get into our interviews for this episode, which will include a special guest, feature articles, and our rapid exchange, I want to announce that we have a special episode available to stream as well. The National Clinical Care Commission was a federal advisory committee charged with leveraging federal policies and programs to more effectively prevent and control diabetes. Its recommendations to the U.S. Congress are included in the February 2023 issue of Diabetes Care, and we have completed a podcast dedicated to this important document, which is well worth the listen.
So we thought we would begin this month's episode with a special guest, the creator of the stunning cover art for the March 2023 issue, Dr. Michael Natter, endocrinologist at NYU Langone Health in New York City. Welcome, Mike, and thank you so much for joining.
Alice, thank you so much for having me. It's quite an honor.
Congratulations on having your art featured. Before we discuss the featured piece, can you tell us about the journey that led you to become an accomplished artist and an endocrinologist?
Well, thank you so much. I'd be happy to talk to you about that. My journey was kind of long and a little bit serendipitous. I was born and raised in New York City and didn't have any medicine in my family, but was diagnosed with type 1 diabetes at the young age of 9. So that kind of opened up this world of the intricate biochemistry and the homeostasis of hormones and metabolism. So I was interested, but shied away from it initially because my strengths really lied more in the humanities and the arts. So that was kind of the thread for me in through college and undergrad. I was doing studio art mostly, but I always had this kind of interest in the medicine. I just didn't think I was good enough or smart enough or cut out for a medicine career. But at the end of my undergrad career, I went ahead and I said, let me try. So I went to a post-bac program back home in New York at Columbia, and I was very, very grateful to have gotten into medical school in Philadelphia at Jefferson Medical College. And I was really drawing a lot of the time throughout my medical undergraduate career. I used my art to really translate the difficult medical concepts into my own visual language. And that didactic form of my art allowed me to excel and kind of understand medicine. And with my own type 1 diagnosis, that kind of personal interest and connection to endocrine led me into that field.
So I got to say, you said humanity and arts, and that is definitely required in medicine. So certainly thankful that you found your way to our side of the field, if you will, but bringing some of that the humanity and the arts to it, which is wonderful. Your featured piece on the cover is titled "Calloused Fingertips." Please tell us about it and the inspiration behind it.
Sure, yeah. So I was diagnosed with type 1 diabetes in 1994. So this is well before the days of the amazing continuous glucose monitors and the technology that we have today. So I was testing my blood sugar, 10, 12 times a day. These are static data points in time. So the only way to really get a sense of trajectory or derivative change is to wait and test again and connect those dots. And you, as a type 1, leave what my friends would call breadcrumbs everywhere. You'd have these used test strips that would kind of find themselves in the crevice of your couch or in your pockets and on the floor. And I remember looking at them one day and saying, there's so much waste I'm generating, and they're so interesting in the colors and shapes that they kind of create when you put them together. It would be cool to make something artistic with them. I didn't know what. I just started collecting them. So I threw them in a box, and they kind of sat on that box and amassed and amassed and amassed. And it wasn't until years later in medical school when the idea of creating a self portrait out of them dawned on me, because there exists this really interesting kind of mosaicism where there's a microcosm of the individual strips, which can represent my everyday, what every type 1 person has to deal with, which is measuring their glucose and taking on that kind of heavy load of being their own pancreas. But then that macrocosm comes into vision when you step back and understanding that you are more than just that chronic disease. You're more than just taking care of your condition. You're a person that's more complex, and you only see that person when you squint your eyes and move back. So I thought it worked really well on those levels, and that's kind of the origin story of that piece.
That's beautiful. It's always beautiful to listen to to the artist and actually understand the inspiration behind pieces that you see, right? And there's always a story behind it. So that was great. Thank you so much for sharing that. And for those of us who want to see more of your art, where do we go?
So most of my art is on my Instagram. It's Mike, Mike dot Natter, and like Nancy, A, T as in Tom, T as in Tom, ER. And then I have some of it on Twitter, which is Mike underscore Natter. And I've been doing some didactic illustrations teaching endocrinology on TikTok. I don't dance, can't do the dancing, but I've been doing some some illustrations on TikTok, which I believe is just Mike Natter at TikTok.
And I have to say I've seen some of those and it's great to be able to teach that way, right? In a very entertaining fashion and certainly well appreciated. So thank you for so much for doing that. And finally, what advice would you give to anyone listening who's thinking about submitting their art to be considered for a cover of diabetes care?
Well, Alice, I think you said it well up front that there is such an inherent humanism and artistic creative essence to medicine. And if we don't celebrate that and recognize that by doing things such as this, by having cover art, it's really kind of a loss for the community. And so I definitely encourage people to express themselves through art and submit for the cover. It not only makes it more interesting and artistic to kind of pick up the copy and read it, it further, I think, enhances the community of people who are practitioners, but also people who live with these diseases and conditions.
That's wonderful, Mike. Thank you so much. So, thank you for sharing your time. Thank you for sharing your talent with us. And for anyone listening who has original art that they wish to submit, please email the American Diabetes Association at productionmanager@diabetes.org or visit the Diabetes Care website for more information. Thank you so much for spending time with us today, Mike.
Thank you for having me.
In the March 2023 issue of Diabetes Care, one of the feature articles is a review entitled Youth-Onset Type 2 Diabetes, the Epidemiology of an Awakening Epidemic. This is a topic that sure grabbed my attention, and I'm delighted to introduce this paper's first author, Dr. Wei Perng, who has joined me to talk about this very important and emerging metabolic disorder. Dr. Perng is Assistant Professor of Epidemiology at the University of Colorado School of Public Health, where she serves as Associate Director of Research, Training, and Education for the Life Course Epidemiology of Adiposity and Diabetes Center. Welcome, Wei. I'm so glad you could join us.
Thank you, Michael. It is my pleasure to be here. Thanks for having me.
And Wei, congratulations to you and your co-authors on this feature article. Your article reviews three main areas. First, the epidemiology of type 2 diabetes among children and adolescents. Second, the clinical course of youth-onset type 2 diabetes. And third, current topics in research aimed at informing diabetes prevention. So let's get into it. To start, what is most important about the present epidemiology of youth-onset type 1 diabetes?
Thanks. This is a great question. I think that the most important aspect about the epidemiology of youth onset type 2 diabetes is that while the prevalence is still quite low, in the US, for example, youth onset type 2 diabetes affects 0.67 cases for every 1,000 youth, which, if you do the math, this comes out to less than 1%. The relative increase in new cases, or the incidence, is rising at an average of about 5% per year. And I know that that number does not sound staggering, but it is concerning because of how aggressive the clinical course of this disease is. And I'll just share that the mantra of the senior author of the review, Dr. Donna DeBelia, is that we really need to pay attention to these trends because even one case of youth onset type 2 diabetes is too many, given the clinical course and also the risk of long-term complications and comorbidities, which are likely to occur during young adulthood. And I think that's a life stage that we can all agree should be the most productive and active years of a young person's life.
Yeah, that increasing incidence is certainly concerning, particularly about what that means for our long-term prevalence rates and how important this disorder is going to become for us in future years. And there's another aspect about the epidemiology that you discuss in your article. That is, youth-onset type 2 diabetes appears higher in terms of prevalence and incidence in females than males. However, you also discuss how during adolescence, the prevalence of prediabetes is in fact higher among males. Can you help us understand this paradoxical sex difference?
Yeah. Before I discuss sex differences in prediabetes, I think it's worth it to mention that we do not know yet what prediabetes is in children and adolescents. The current definition of prediabetes in youth is really just an extrapolation of adult thresholds that are indicative of impaired fasting glucose or having blood sugar levels that are higher than they should be after one has not consumed anything for 8 to 10 hours, as well as impaired glucose tolerance, which refers to having elevated blood sugar levels 2 hours after having consumed a 75-gram glucose load, and or elevated hemoglobin A1C, or abbreviated as HbA1c. So before we can draw firm conclusions about prevalence and trends and sex differences in prediabetes among children and adolescents, I think we still need to determine how well the current definition predicts full-blown type 2 diabetes in youth, and perhaps more importantly, take a de novo approach to identifying age-appropriate definitions of prediabetes for children and adolescents. Now, having said this, I don't actually think there's a clear answer to your question regarding why there's a higher prevalence of prediabetes in male adolescents and yet higher rate of type 2 diabetes in female adolescents. One hypothesis is that puberty is more metabolically harmful for some individuals than others. And perhaps in this context, the physiological changes of puberty may predispose females to progress from prediabetes to full-blown type 2 diabetes through an interaction with female sex hormones like estrogen. Another explanation revolves around heterogeneity in the definition of prediabetes, which comprises having impaired fasting glucose or impaired glucose tolerance. And studies in adults have found that males tend to have a higher prevalence of impaired fasting glucose than females, whereas females have a higher prevalence of impaired glucose tolerance than males. Now, the two conditions, impaired fasting glucose and impaired glucose tolerance, likely have etiologically distinct underpinnings, as well as differential implications for future diabetes risk. So it could be that the sex paradox observed with respect to progression of prediabetes to type 2 diabetes may simply reflect pre-existing differences in the composition of prediabetes among male versus female youth.
That's terrific. So it's again another example of children are not just small adults, and we really need to be thinking about appropriate age-specific definitions that also, it sounds like, are important to be sex-specific, as development and puberty are different in males and females, and that likely will affect the meaning of any abnormality in measured glucose for future prediction of type 2 diabetes.
Yes, exactly.
So let's consider the clinical course now of youth-onset type 2 diabetes. In the article, you point out that youth-onset type 2 diabetes is associated with higher rates of diabetes-related complications than type 1 diabetes. How is this occurring? And given the epidemiology we've discussed, what are the future implications of this increased rate of complications?
Yeah, the higher burden of diabetes-related complications among youth affected by type 2 diabetes is a direct reflection of its aggressive clinical course, which is characterized by a faster rate of decline in the beta cells and also relatively low responsiveness to pharmaceutical treatments that otherwise have worked quite well in adults with type 2 diabetes. Now, in terms of the comparison to other types of diabetes in youth, so specifically type 1 diabetes, data from the Search for Diabetes in Youth study, which is a population-based study that surveyed physician-diagnosed diabetes in 5 US states, plus select American Indian reservations, that was intentionally designed to compare the clinical course of youth-onset type 2 versus type 1 diabetes, found that the greater risk of complications among cases of type 2 diabetes was not explained by disease duration or glycemic control, but rather by race and ethnicity. And I think this is really important because it really points toward a critical role of social circumstance as an upstream driver of youth-onset type 2 diabetes pathophysiology, as well as prognosis. And accordingly, I think a really important future direction is to have a stronger focus on social factors and their role in relation to chronic metabolic conditions like type 2 diabetes.
That really helps to understand the disproportionate burden of diabetes-related complications that are experienced by youth from minority populations and how social determinants of health may be contributing to this. Do you have any suggestions on what we can do about it?
So you mentioned social determinants of health, which is defined as the conditions into which we are born, live, play, and work. These are central to indisputable inequities in youth-onset type 2 diabetes, as well as other socially patterned chronic conditions. And one of the best illustrations of the role of social determinants that the senior author on this review frequently shares is the markedly higher rates of type 2 diabetes among Pima Indian youth in the US versus those in Mexico, which really reflects this effect of nurture over nature. Now, in terms of how social determinants of health contribute to youth-onset type 2 diabetes and its related complications, I tend to think of this as two kind of distinct categories. So the first category comprises social privileges or lack thereof. So I'm talking about things like educational attainment, health literacy, knowledge of how to access and navigate the healthcare system, etc. These social privileges also include physical environments that are free of exposure to toxic pollutants and that can otherwise trigger pathogenic pathways that underlie development of metabolic disease, such as insulin resistance and inflammation. Additionally, the physical environment also includes the built environment, which can be assessed by metrics like walkability and neighborhood safety, which can either promote or impede regular recreation and exercise, which we know are preventive factors for developing type 2 diabetes. The second way by which social determinants of health affect type 2 diabetes is through stressful social experiences. For example, experiences of bias and discrimination that can trigger the hypothalamic pituitary adrenal axis, which then leads to sustained low dose elevations in inflammation and stress hormones that can then trigger pathophysiological pathways that exacerbate and promote metabolic disease development. And the question of what we can do about social determinants of health is a really important focus of current and what I hope will be future research. The answer is that it's complex and it likely requires multi-level interventions that comprise systems-level structural change. So, for example, large-scale initiatives to improve access to preventive healthcare, if we're going to talk about preventing type 2 diabetes in youth. This will also require meso-level or community-level changes like improving neighborhood walkability, safety, and fresh food access. And then finally, of course, we need individual level changes, which in my mind can be quite challenging, along with the other types of changes, but these really require modifications of health and lifestyle behaviors.
And certainly modeling those behaviors requires the ability to have a appropriate built environment, access to nutritious foods. And this has been a topic discussed recently on this podcast. We covered the recent National Clinical Care Commission report to Congress that appeared in the February issue of Diabetes Care. And the National Clinical Care Commission report made recommendations to address diabetes at 3 levels: the population in general, the population with prediabetes, and the population with diabetes. How do you see this report influencing the outlook for our at-risk population of youth?
Thank you so much, Michael, for pointing out and sharing the recent NCCC report. Thanks to you, I read the article and I agree with the need for a multi-pronged approach to address the social and environmental conditions that place individuals at risk of type 2 diabetes, while also enhancing healthcare coverage and access and facilitating federal approval of medications that show promise for diabetes prevention. And I think the specific one mentioned was metformin. In terms of how I see this report influencing the outlook for at-risk youth, I will start by saying that I wholeheartedly agree with the multi-level prevention approach, which comprises systems-level federal policy, community-level prevention programs and workforce development, practice-level capacity to support technology-enabled interventions, and patient-level engagement and training. Now, the key difference when contemplating prevention strategies in children as opposed to adults is this idea that children's health is often not within their own volition. And yet, pathogenesis of many chronic conditions, including type 2 diabetes, begins very early in life. So, in utero, if not even before that. Accordingly, to effectively prevent these early onset metabolic diseases, there really needs to be a broader consideration of life course health and a ramp up of prenatal prevention in high risk populations. Additionally, I want to highlight that we still do not know enough about the pathophysiology of youth onset type 2 diabetes, which is quite heterogeneous and likely more so than adult onset type 2 diabetes. So, to this end, gaining a better understanding of the sequence of physiological events that culminate in clinical disease through high quality life course research comprising long term observational cohort studies is a very important first step to identifying targets for preventive intervention.
And related to that, Way, you describe in your article an intergenerational cycle of type 2 diabetes, whereby maternal diabetes is associated with in as much as sevenfold increased risk for youth onset type 2 diabetes developing in offspring. What may be contributing to this extraordinarily strong risk factor?
This is my favorite question to answer. So, I think that there are three reasons for this strong relationship between maternal diabetes and offspring diabetes. The first, and probably most obvious, is shared genes between the mother and child. Anytime we look at maternal child health, genes are always a component. Although we now have evidence from sibling studies and other types of clever designs that genetics is not the only factor at play. The second reason is the shared family environment, which includes shared physical and social exposures that may be risk factors for poor glycemic control, as well as similar lifestyle behaviors. Finally, there is this notion of in utero programming, or the idea that a woman's health and lifestyle while pregnant, or maybe even around the time of conception, carries long-term consequences for the health of her offspring. This is the central hypothesis of the developmental origins of health and disease paradigm, or DOHAD for short. And with now over 3 decades of DOHAD research, we know that the in utero period is one of the most sensitive and important developmental stages for programming risk of metabolic diseases like type 2 diabetes. And of course, none of the three factors that I just described operate in isolation. They accumulate over time, and they very likely interact with one another in a synergistic fashion across the life course to prevent or promote disease development.
And that's so important to really consider how taking care of the whole family and across generations and prevention of diabetes is really as important in adulthood as it is in childhood. And that hopefully this increased attention to the importance of prevention programs, reimbursement for diabetes prevention, and advocacy for improvements in nutrition and environmental factors, as well as social constructs that may make it more achievable to mitigate this this risk, particularly among our most vulnerable youth, families, and minorities that have been most impacted by type 2 diabetes, and particularly that occurring in childhood. Wait, do you have any final takeaway messages for our readers?
Yes, I appreciate the opportunity to close this out. So, to end, I will reiterate the takeaway messages at the end of the review. I think some of our priorities are to first, we need systematic surveillance of the entire spectrum of youth onset type 2 diabetes, from normal glycemia to dysglycemia to full blown diabetes, especially because youth onset type 2 diabetes is still a relatively new pediatric condition that did not exist and was not recognized clinically 4 decades ago. Second, we need to continue conducting high-quality research that will improve understanding of youth-onset type 2 diabetes pathophysiology, which in turn will provide insight into the spectrum of this condition in children and adolescents and aid in identifying high-risk youth to focus on for preventive action. Third, given that the risk of chronic conditions begins in utero, we really need a holistic approach for identifying lifetime exposures and experiences that independently and interactively promote risk of type 2 diabetes so that we can determine when and how to most effectively break this intergenerational cycle. And finally, kind of coming full circle to what we discussed earlier, we need multi-level, multi-pronged intervention and prevention strategies that span systems, communities, families, and individuals. This part is not unique to youth-onset type 2 diabetes, but rather applies to many complex chronic conditions. And so I think achievement of this last point, which is no small task, can be beneficial to a number of leading chronic diseases.
Thank you so much, Dr. Perng. I really appreciate your joining us today and impressing upon our readers the urgent need for a concerted effort across public health and policy initiatives, as well as clinical practice and biologic research, to develop cost-effective and accessible strategies to protect our youth and turn the tide back against this emerging epidemic of youth-onset type 2 diabetes. I encourage our listeners to access the full article in the March issue of Diabetes Care.
One of the feature articles from the March 2023 issue of Diabetes Care is titled Roux-en-Y Gastric Bypass Increases Glycemic Excursions During Pregnancy and Postpartum, a Prospective Cohort Study. I'm happy to be joined by the lead author, Dr. Louise Stentebjerg, an obstetrician and PhD candidate at the Steno Diabetes Center Odense in Denmark. Thank you very much for joining, Louise.
I'm delighted to join in.
Congratulations to you and your team for this feature article. Prior to your study, there were limited data on the impact of Roux-en-Y gastric bypass on glucose metabolism in pregnancy. Can you tell us why was it important to address this topic and what were the specific questions that you wanted to answer?
Well, thank you. We are thrilled that the Diabetes Care find our results as important as we do. In our clinic in Denmark, we encountered women with gastric bypass who experienced symptoms of hypoglycemia, and therefore we did a systematic review and a meta-analysis on hypoglycemia in pregnancy following gastric bypass. And we found that hypoglycemia was prevalent, especially during all glucose tolerance tests performed for the diagnosis of Steno diabetes. And therefore, all glucose tolerance testing is no longer recommended in pregnancy following gastric bypass. All these previous studies only tested once during pregnancy, and therefore we wanted to investigate the time spent in hypo and hyperglycemia, and we wanted to investigate what happened during the course of pregnancy as the insulin sensitivity decreases. We know it decreases about 50% from early to late pregnancy. And we also wanted to investigate whether women exposed to hypoglycemia during pregnancy could be identified by specific clinical characteristics that could be used for risk assessment. And lastly, we know that the offspring of women with gastric bypass weigh a few hundred grams less than matched controls. And just as offspring of women with hyperglycemia are at risk of increased fetal growth, we wanted to investigate whether the reduced fetal growth among women with gastric bypass is associated with the time they spend in hypoglycemia.
All excellent questions that needed to be addressed. And you make a great point. I mean, we often think a lot about hyperglycemia in pregnancy and maybe not as much about hypoglycemia. So great questions to ask, which then leads me to my question to you is then how was the study conducted? And also, and I love this part, what does it have to do with a beloved Disney character?
For the first part, we did continuous glucose monitoring for 10 days in each trimester of pregnancy, and then 4 to 6 weeks postpartum in 23 women with gastric bypass and 23 women matched on BMI and parity. And we extracted their medical history and included characteristics of the bariatric surgery and the pregnancy, birth, and neonatal outcome. And for the acronym of the study, we like the analogy with the Disney character and his experience on ice. We need to check that the water is stiff, that it is safe to get pregnant following gastric bypass surgery. And if there are problems, we need to see how to overcome these. And Bambi has his rabbit friend Thumba, who tells Bambi to watch both ends at the same time. And this also applies to these women. They are at increased risk of both hypo and hyperglycemia. So we too need to watch both ends at the same time when we care for these women.
Love it. So you've got both Bambi and Thumper in there, right? And Bambi, just to clarify, was the acronym, right, for the larger study?
Yeah, it's short for bariatric surgery and consequences for mother and baby in pregnancy. So we found the Bambi letters in there.
Fantastic. So, Louise, let's start off with the CGM metrics or the continuous glucose monitoring metrics. Were there differences between the groups and during the different phases of pregnancy as well as postpartum?
There definitely were. If we start with the hypoglycemia, we found that time spent in hypoglycemia was higher among the women with gastric bypass compared to the matched controls. And furthermore, for the women with gastric bypass, there was an increase in time spent in hypoglycemia during pregnancy, and then a decrease in the postpartum period, opposite of what we were expecting from this decreasing insulin sensitivity during the course of pregnancy. And we found that women with gastric bypass spent twofold time in hyperglycemia compared to the BMI matched controls. And their time in hyperglycemia did not increase during pregnancy as we expected. For the women with gastric bypass, they spend about 9% of the time in hyperglycemia throughout pregnancy and in the postpartum period. And these numbers actually corresponds to numbers reported in women with gestational diabetes. But in our cohort, we only found 2 women we diagnosed with gestational diabetes according to our current Danish national standards for these women.
Interesting. Now, you mentioned that women treated with Roux-en-Y gastric bypass had an increased risk of time below range, or perhaps an increased time below range, maybe the better way to phrase it. Were there predictors of this that could be used in clinical practice?
Yeah, unfortunately, we did not have power to do a multivariate analysis, but in our univariate analysis, we found that longer surgery to conception interval, a lower nadir weight, and greater weight loss were all associated with having an increased time in hypoglycemia, and they could serve as warning signs for clinicians.
So was there a relationship then between the interstitial glucose levels and the birth weight?
Again, unfortunately, we lack power to draw definite conclusions, but women treated with gastric bypass who gave birth to small for gestational age neonates spent slightly increased time in both the low and the very low ranges compared with those who delivered babies of appropriate weight for gestational age and the large for gestational age neonates. And furthermore, these women spent less time in hyperglycemia. In contrast, women treated with gastric bypass who gave birth to large for gestational age neonates spent less time in hypoglycemia and more time in hyperglycemia. But we had too few women and babies to have statistical significant differences. So we need more women if we should draw definite conclusions on this point.
So then that leads very nicely to my last question then. So what are the next steps?
We are actually planning a sequel, the Bambi 2 study. This study will be powered to detect differences in birth weight, and since sleep gastrectomy has surpassed gastric bypass in frequency during the last decade, it will include both women with gastric bypass, sleep gastrectomy, and also BMI matched controls. In the Bambi 2 study, we will investigate further how we properly diagnose gestational diabetes in these women. We will investigate predictors associated with hypoglycemia and whether there actually is an association between hypoglycemia and reduced fetal growth.
Excellent. And those questions are very important to answer because as we see more and more women having had some sort of metabolic surgery and then going for pregnancy, I think it's critical that we get those questions answered. So thank you very much, Dr. Louise Stentebjerg, for sharing your expertise with us today and for helping to expand the understanding of the impact of Roux-en-Y gastric bypass on glucose metabolism in pregnancy. And we certainly look forward to you and your team's work to answer those other questions and sort of expanding to other types of metabolic surgeries as well. And I encourage the listeners to read the full article in the March issue of Diabetes Care. Let's move on now to a segment we call Diabetes Care Rapid Exchange, where Mike and I get to chat about a few other articles we found particularly interesting.
Thanks, Alice. The first article I'd like to call out is authored by Dr. Mark Rigby from Janssen Pharmaceuticals and colleagues and provides 2-year follow-up from the TIGER study. Now, TIGER was a phase 2 randomized clinical trial that assessed administration of the TNF-alpha blocker golimumab for 52 weeks on progression of type 1 diabetes in recently diagnosed children and young adults. At 52 weeks, preservation of endogenous insulin secretion was previously reported, and now the article demonstrates maintenance of an increased C-peptide area under the curve in the golimumab compared to placebo group at 104 weeks, 52 weeks after discontinuation of study drug. Importantly, there's a group of golimumab responders that could be identified with particularly impressive C-peptide preservation and improved metabolic control on therapy that persisted above that observed in the placebo group during the 52 weeks following study drug discontinuation. These responders are particularly interesting as potential candidates for continued immune intervention therapy. And hopefully, these results will add to the future armamentarium of potentially disease-modifying therapies that could offer a personalized, targeted intervention aimed at arresting the progression of autoimmune diabetes.
I got to say, it's been pretty exciting watching this field evolve over time, right? And I'm certainly hopeful that, certainly before I retire, that there will be a very different approach to people living with type 1 diabetes, either newly diagnosed or related people. I think it'll be pretty exciting to watch this field grow. So for the next one, the sayings, a little goes a long way, or a little bit of this and a little bit of that certainly come to mind. Dr. Tosif Khan and colleagues in Toronto, Canada, led by Dr. John Sievenpiper, asked the question if combining low-risk lifestyle behaviors, such as healthy body weight, healthy diet, regular exercise, smoking abstinence or cessation, and light alcohol consumption, was associated with lower risk of incident type 2 diabetes. They performed a systematic review and meta-analysis of 30 cohort comparisons involving over 75,000 incident type 2 diabetes cases. Not surprisingly, these low-risk lifestyle behaviors were linked with lower risk of type 2 diabetes, but what struck me was the magnitude of reduction. Maximum adherence to all 5 low-risk lifestyle behaviors lowered risk of type 2 diabetes by a whopping 85% with high overall certainty of evidence. So, as usual, Mom was right. I think we just need to learn to do the right things and live healthy.
Yes, indeed, Alice. We all need to be working hard every day to set those goals in our sights and sticking to the theme of diabetes prevention. Now I'd like to turn our attention to type 1 diabetes, where Dr. Gerald Wilson from Stanford University School of Medicine and colleagues used continuous glucose monitoring metrics to identify individuals with prediabetes at risk for progression to clinical or stage 3 type 1 diabetes in the TrialNet Pathway to Prevention study. They analyzed 95 individuals with stage 1 or stage 2 preclinical type 1 diabetes using 7-day continuous glucose monitoring and oral glucose tolerance tests. It turned out that spending more than 5 to 8% of time with a sensor glucose greater than 140 or 160 milligrams per deciliter were each associated with progression to stage 3 clinical type 1 diabetes. What's important is that these relationships were significant, even for those who had a quote unquote normal oral glucose tolerance test. And so periodically evaluating autoantibody positive individuals for dysglycemia with a diagnostic continuous glucose monitor may help to select those individuals for possible immune intervention at greatest risk for disease progression.
And certainly a valuable addition to our understanding of maybe from a clinical perspective, right? How we're going to be able to identify the right people to offer these disease-modifying therapies in the future. So exciting. The relationship between gestational diabetes and increased future risk of developing type 2 diabetes in the mother is well established. What's not as clear, though, is the relationship between gestational glucose tolerance groups and postpartum maternal glycemic status, and also whether treating the GDM impacts that future risk. To answer that, Dr. Ravi Ratnakaran and colleagues, again from Toronto, looked at the metabolic test results at 3 months and 1 year postpartum in 599 women who belonged to one of 5 groups, either normal glucose challenge test and oral glucose tolerance test, abnormal GCT with normal OGTT, gestational impaired glucose tolerance, or mild untreated GDM, and then finally severe treated GDM. So 5 different glucose groups. Birth weights steadily increased as the glucose tolerance groups increased, but then dropped off in the treated GDM group, confirming the utility of treating GDM. However, insulin sensitivity and beta cell function progressively decreased across the 5 groups, and the prevalence of prediabetes and diabetes at 1 year increased in a stepwise pattern, suggesting that treating GDM lowered birth weights but does not change the future maternal glycemic status.
Really important findings, Alice, and resonate with results published in January's issue of Diabetes Care we discussed on this podcast, that even women with impaired glucose tolerance during pregnancy have an increased risk for future diabetes. So clearly, women with gestational glucose intolerance need careful long-term follow-up for diabetes, regardless of how well their glucose may be controlled during pregnancy. For the next article, I'd like to shift to the area of complications. Viktor Kurovich from the Steno Diabetes Center in Copenhagen and colleagues conducted a randomized crossover trial of 4 different classes of urine albumin-lowering drugs. 61 adults participated who had either type 1 or type 2 diabetes, and they were exposed to 4-week periods of the angiotensin receptor blocker temolsartan, the SGLT2 inhibitor empagliflozin, and the DPP4 inhibitor linagliptin, or the JAK STAT inhibitor baricitinib. This was then followed by re-exposure to the agent producing the largest reduction in urinary albumin excretion for that individual. Not surprising, temolsartan was the best performing drug for just over half the participants, yet each of the other drugs turned out to be the best performing intervention in a similar proportion of the remaining participants. And what's most striking is that this inter-individual variation in drug class response was reproducible upon re-challenge in this patient cohort, arguing that individualizing treatment assessment to reduce albuminuria in those resistant to inhibition of the renin-angiotensin system may be the most efficient path forward.
So sort of another nod to the concept of more personalized medicine, right? And really figuring out what's going to work for the person sitting in front of you. Another area for us to keep an eye on. One of the other editor-featured articles in the March 2023 issue is a retrospective cohort study looking at glucagon fill rates and expenditures in a nationwide cohort of over 2.8 million adults with diabetes between 2011 and 2021. Of concern, glucagon fill rates are low and have decreased over time from 2.91 to 2.28 per 1,000 person years. That is among all comers. For the groups at high risk of severe hypoglycemia, fill rates were thankfully better and increased over time, but were still disappointingly low. For example, among those with a history of severe hypoglycemia, the rates increased slightly from 16.08 to 20.12, but again, per 1,000 person years. Fill rates were lower among minorities, males, lower income individuals, and Medicare Advantage patients. Between 2011 and 2021, total cost per dosing unit increased a concerning 74% among commercial beneficiaries and a discouraging 95% among Medicare Advantage beneficiaries. I'm hoping that analyses like these will inspire changes to improve access to this really potentially life-saving therapy.
Thanks, Alice. These are somewhat surprising results given the recent increase in the number and types of glucagon formulations available for emergency treatment. Clearly, there is more work necessary to increase awareness and access, and this paper again emphasizes the need to address the increasing disparity in diabetes treatment that is developing alongside the availability of new drugs and technologies.
Well said, Mike. So I guess this brings us to a close for this month's episode of Diabetes Care on Air. A huge thank you to Drs. Natter, Stentebjerg, and Perng for sharing their insights with us.
And a reminder to everyone to submit their original art for consideration to be included on a future cover of Diabetes Care. And a big thank you to all of you for tuning into this episode. We welcome your comments and feedback, and don't forget to subscribe to this series and get notifications when a new episode comes out. Thank you for listening.